Ah, yeah.
Good evening, sir.
Good evening. So sorry, there was some problem.
Good evening, Dr. Sumit.
And good evening. There was some problem at my net. So I'm around.
Dr. Devashish is also joined. Tavish, get ready for streaming.
Okay, sir. Yes. Okay.
Good evening, sir.
Good evening, Ashish.
Good evening, Dr. Devashish.
Good evening, Dr. Gulshan. So are we ready?
Dr. Gulshan, should we start the streaming?
Yeah, sure. Dr. Devashish, should I start the introduction part?
Yeah, sure.
I'll just
So,
give a countdown. We'll start in 3, 2, 1, go.
good evening, everyone, and a very warm welcome to today evening's webinar, Headache Expert. We have with us today eminent faculty Dr. Devashish Chaudhary, Dr. Sumit Singh, and Dr. Ashish Duggal. Dr. Devashish Chaudhary is the Vice Chairman and Academic Head, Department of Neurology, BLK Max Super Speciality Hospital, Delhi. He is the President of the Headache Society of India, past President, Indian Academy of Neurology, past President, Delhi Neurological Association, former Director, Professor and Head and Chair of Academics, GB Pant Institute of Postgraduate Medical Education and Research, New Delhi. A very warm welcome to you, sir. Dr. Devashish, may I please request you to take the session ahead?
Right. Thank you. Thank you, Dr. Gulshan, for a kind introduction. Good evening, everyone. It has been a pleasure to be here on this platform because this is quite a kind of an historical importance because this is the first webinar for educational purposes that is being hosted by the Headache Society of India. You might not be aware of this. Now we have got this fully functional organization called Headache Society of India, which is spearheading the headache medicine and awareness among the doctors as well as the patient groups. So we have got 3 talks today. And we have besides me, we have 2 other eminent headache experts. One is Dr. Ashish Duggal, who would be taking the first talk. And Dr. Ashish Duggal is is a professor of neurology working at RML Hospital in New Delhi. And he is also the treasurer of Headache Society of India. And he will be talking on the diagnosis behind the obvious of migraine. So basically, he is going to dwell upon the clinical features and what are the other possibilities that you should keep in mind while diagnosing headache. The second speaker will be Dr. Sumit Singh, and he is a very well-known neurologist and headache specialist. He is the director and head of the Department of Neurology at Artemis Hospital, Gurgaon. And he will be talking about the acute management of migraine and after Dr. Ashish. And finally, I'll be taking the preventive therapy of migraine. Now, I would request everyone to put your questions, queries in the chat box so that we can take them once each and every talk is over. So first two talks will be moderated by me, and the last talk will be moderated by Dr. Sumit. And I hope that this will be quite an educational feast for all of you who are editing this meeting.
Dr. Francis and Professor Girish have joined, sir.
Okay, so then let me request Dr. Francis and Dr. Girish to be moderating the first two sessions, and the last session, Dr. Sumit, you moderate. Okay. So the
No
first session, Dr. Francis, the second session, Dr. Girish, and the third session by Dr. Sumit. Okay. So may I request Dr. Ashish Dugal to kindly share his screen and start with the presentations right away. Thank you.
Thank you, sir. Thank you for the kind introduction. Thank you. And as Dr. Debashish sir just pointed out, this is the first webinar of Headache Society of India. And I hope that under the society, we continue to provide education and information about headache, and the society grows as in the future. So I'm going to talk about migraine diagnosis beyond the obvious. So migraine is not just a headache. So we all know that there is headache in migraine, but migraine is basically a state of brain hyperexcitability as a result of the cortical spreading depression, hypothalamic brainstem activation, and trigeminal system mediated neurogenic inflammation, which causes the headache, which then amplifies the brainstem, and the hypothalamus then amplify the headache, resulting in a myriad of symptoms, not just headache, but then patients can have special sensory phenomena, somatosensory phenomena, motor phenomena, autonomic involvement, cognitive involvement. And besides this, they can also have an interictal sensitivity. Now, it is easy to diagnose the headache part of migraine. What is probably more difficult and challenging is the things which surround the headache. That is the prodrome, the aura, and the postdrome. And these are the stages in which diagnostic confusion can arise, because diagnosing headache in the migraine is very easy. There are specific criteria. And if you take a proper history, you will very easily make a diagnosis of migraine. But the prodrome, the aura, and the postdrome, in these, the kind of variable symptoms that the patients can present, they can cause diagnostic uncertainty. Then there can be various variants of migraine which can be confused with other disorders such as vascular disorders, epilepsy, other primary and secondary headaches, and obviously functional disorders. Migraine is such a common disease that 15 to 25% of general population is affected by it. And so the uncommon manifestations of migraine may be in fact more common than the frequent manifestations of the less common diseases. So since migraine, for diagnosing migraine, we do not have any biomarker, we do not have any imaging. So we totally rely on the International Classification of Headache Disorders, currently in its third version, for diagnosis of migraine. And this classification is very used. And several studies have found that by sticking to this, a proper diagnosis of headache disorders can be made very easily. However, there are, like all classifications, there are some lacunae in this. So, for example, this classification, there are criteria for this are very stringent for the pediatric and the atypical cases. The ICHD classification requires a 5-attack minimum, so there may be a delay in diagnosing migraine and episodic migraine if the episodes are less frequent. Then you need to distinguish aura from other focal episodic neurological symptoms like TIA and epilepsy. Although the ECG classification gives very good distinction, but still one needs to be aware of those. Then the classification is more focused on the classic symptoms like nausea, vomiting, photophobia, phonophobia, but patients can have other symptoms like vertigo, dizziness, or cognitive issues, osmophobia, and limb pain and body pain, which can confuse the clinician. Then there is a risk for misdiagnosis, again, primarily because of the fact that there is a 5-attack minimum. And finally, there may be some validation issues in specialized types like migraine with brainstem aura and menstrual migraine. So as per ICHD, the diagnosis of migraine without aura this is very straightforward. The patient should have episodic headaches which last for 4 to 72 hours with any two of the following, that is unilateral, pulsating, moderate or severe, or worse with movement. And then they should have any one of nausea and or vomiting, photophobia and phonophobia. So they should fulfill all these 4 criteria. But in actual, patients may have bilateral headache, or the headache side may vary during a single headache. They may have a milder headache which may not pulsate. It may be continuous as in chronic migraine. And in some patients, particularly children, the headache duration may be less than 4 hours. And more importantly, it's important that the untreated headache duration should be more than 4 hours. So if a patient takes a acute abortive medication for migraine and the headache resolves in 2 hours, then that doesn't mean that he doesn't have migraine. So one should always ask how long the headache lasts if the headache is untreated. And in some patients, it may last for more than 72 hours. And in some patients, as I told, the classic accompaniments may not be there. And some patients can have an aura without headache, as we will see later. And some patients can have interictal hypersensitivity, which can cause, again, diagnostic confusion. For migraine with aura, which is though less common, but is seen in around 10 to 20% of the patients. And the criteria require that there should be at least 2 attacks with an aura, which could be either a typical aura, that is a visual, sensory, or a speech or language aura, or it could be a brainstem aura, or it could be a motor aura, or it could be a retinal, that is monoocular vision aura. So either of one or more of these auras should be present. And then there should be at least 3 of the following 6 characteristics. So the aura should progress, spread over a time of period of at least more than 5 minutes. Either 2 or more symptoms should occur in a succession. Each individual aura lasts for 5 to 60 minutes. At least one aura is unilateral and at least one aura is positive. And the aura is accompanied or followed within 60 minutes by a headache. Now, again, here there could be some problems while diagnosing an aura. So it could be an atypical aura in the form that the patients can have cognitive spatial impairments, visual or sensory distortions, which we'll be discussing later. There could be a prolonged aura lasting for more than 60 minutes. Sometimes the aura can start after the headache. So for diagnosis, you require that the aura should occur before the headache. But in some patients, aura can start after the headache. And it has been seen that in patients with whom the aura starts after the headache is usually of a TTH phenotype rather than a migraine phenotype. And then the physician could misinterpret the symptoms, the context of the symptoms, and the symptoms themselves. So epilepsy or a TIA could be diagnosed as aura or vice versa. So when we look at the ICSD classification, the most important thing is that they require you to exclude any other cause of headache in the ICSD classification. So when there is a classic history of migraine with a patient coming who has a episodic headaches for a long time, then that may not be a problem. But the problem arises when there is a new onset headache. So we need to be aware of certain danger signs or red flags which should be looked for in all patients with migraine. So this is a mnemonic Snoop 4, which one can use for looking for the red flags of migraine. So basically, it requires that there should not be for sensory systemic symptoms or secondary risk factors, any neurological symptoms or signs like altered consciousness, focal deficits. Most importantly, if there is a thunderclap or abrupt onset, the headache peaks in less than 1 minute, this is a huge red flag. Most likely, usually it occurs because of subarachnoid hemorrhage, or it occurs because of a reversible vasoconstriction, RCVS, cerebral vasoconstriction syndrome. And the tempo of the headache, how quickly it peaks, should always be asked. And if there is a headache that peaks in less than 1 minute, this is a huge red flag. Headache starting in the elderly, one should look for giant cell arteritis or a mass lesion. Always ask whether the headache is positional, whether it changes with after lying down or sitting, because it may indicate either intracranial hypotension or dysautonomia. Then if there is a change in character from baseline, now that could be indicating that a patient who has earlier had a baseline headache now has a different disorder. Most likely could be a mass lesion. So evaluation should be done. Always in a patient with headache, especially a patient who is having a chronic headache or a daily headache, papilledema should be looked for. A fundus examination should be done to rule out idiopathic intracranial hypertension, particularly young obese females. And look for if the headache is precipitated by Valsalva, coughing or sneezing, because it may indicate a posterior fossa lesion. Then there are certain yellow flags which can be seen in primary headaches like migraine. But then again, these require some amount of investigation, because they can also indicate a secondary cause. For example, a new onset side blocked headache. Now, this could be a trigeminal autonomic cephalalgia, or otherwise it could also be due to head trauma, dissection, or intracranial aneurysm. And if the headache wakes up the patient from sleep at night, then this again indicates that there could be a secondary cause. So this can also be seen in migraine, cluster headache, and hypnic headache, which are primary headaches. Now, coming on to the clinical phenomenology of migraine. So as I told, migraine is just not the headache. There is a prodrome and there is a postdrome. And as you can see in this figure, the prodrome and postdrome both can last for up to few days. So in all, this can be the duration of this whole attack could be longer than 72 hours if untreated. And the fact is that prodrome is seen in 80% of the patient. And early recognition is important, particularly now, because now we are getting drugs which may be helpful in prodrome. For example, GPANs, which will probably be discussed in the next lecture. Now, coming on to the postdrome, which occurs after the headache. So again, here the patients can have inability to concentrate, fatigue, depressed mood, lack of comprehension. Again, this causes increased disability. And because of these prodrome and postdrome, it is possible that these may be misdiagnosed as something else rather than migraine. Now, coming on to interictal sensitivity. This is also important because migraine is the brain of the migrainer is a genetically susceptible brain to persistent sensory stimuli. So there is basically a persistent sensory hypersensitivity, and these patients have lower thresholds to visual, auditory, and somatic stimuli. As a result, there is abnormal sensory processing loop. So the thalamus, which acts as a gate for the sensory stimuli, it decreases the filtration, causing increased excitability and decreased inhibition of the cortex, resulting in a deficient habituation, and basically the sensory perceptions are amplified. So how it is important clinically is that these patients, particularly if they're having recurrent headaches and chronic headaches, they can have interictal photophobia, phonophobia, allodynia in the form of limb pain, on osmophobia, which can be present even without headache. This not only causes considerable disability, but again, as I told earlier, this could be responsible for misdiagnosing migraine. Now, coming on to the aura. Now, this is the most fascinating part, though this is not seen very commonly, but one should be aware that patients with visual aura, they can be again misdiagnosed as either seizures, transient ischemic attacks, or amyloid spells. Now, basically, visual aura is the most common aura. There are the patients have flashing lights or zigzag lines. So there is a positive scotoma followed by positive symptoms followed by a negative scotoma. Though sometimes the patients may not observe a negative scotoma and they may only tell about you about the positive phenomena. Now, if the margin of the scotoma has a pattern like battlement of a cattle, it is called as fortification spectrum or tachopsia, as is seen in the figures here. Now, usually the visual aura starts in the center and then it progresses to the periphery and then finally it disappears. Though rarely it can have a reversal of pattern starting in the periphery and then coming on to the center. Sometimes it can occur without the headache. So it is known as ecaphalgic migraine or typical aura without migraine, and also known as late life migraine equivalents. So usually the aura is uncolored, but less commonly there may be colors. Majority wise, it's limited to one hemifield, but in 30% it may be bilateral. Now, coming on to the sensory aura, again, this is fully reversible hemisensory symptoms. Usually these occur in a stereooral distribution. So it starts in the fingertips, gradually progresses to the limb and then to the lips. And the trunk and the lower limbs are involved, but less commonly. Mostly it involves the upper limb and the face because the sensory homunculus is like that. So the paresthesias may sometimes spread to tongue. And this is an important feature because this helps in differentiating from TIA, in which tongue paresthesias are usually not seen. So following the paresthesias, there can be numbness and the sides may change from attack to attack. Coming on to the language aura, which is the third of the typical auras. Those speech aura, which consists of fully reversible dysphasic speech disturbances. Now, speech aura could either be dysphasia, in which the patient can have paraphasias, other language auras, or they can have impaired comprehension. It can also be dysarthria, or it can sometimes be not classified. So it may not be easy to classify that it is dysphagia or a dysarthria. Now, sometimes because aura is occurring because of the cortical spreading depression. So it starts from the occipital lobe and goes anteriorly through the parietal lobe and to the frontal lobe, causing the visual, sensory, and the dysphasic aura. But then it can also spread to some other areas of the brain and cause atypical auras, which could be cognitive or perceptual manifestation. These are rare, but one should be aware of them because uh, these can be seen in, mostly can be seen in secondary causes. So these doesn't mean that this is migraine, but one should be aware that this can occur in migraine. And if they are occurring, obviously we need to rule out other causes. So imaging should be done. So patients can have neglect and spatial inattention. They can have geographical disorientation. So they may have difficulty recognizing locations or physical surroundings. And they can have a transient global amnesia, metamorphopsia or visual distortions. They can have olfactory hallucinations, palinopsia, where there is a visual preservation of persistent or recurring images. Then they can have macropsia, micropsia, telescopic vision. Alice in Wonderland phenomena is one of the cognitive perceptual manifestations of migraine aura. So if these are present, obviously one should rule out secondary causes in such an aura. Always an imaging should be done, but this can occur in migraine also. Now, coming on to the motor aura. So motor aura basically occurs in hemiplegic migraine. And this is a... I'm sorry, this video is not working. Sorry. So this was a patient who had a visual aura followed by sensory aura, and then he had a motor aura where there was hemiparesis, which lasted for 3 to 4 hours. Now, in a hemiplegic migraine, you need to have at least one of the fully reversible auras: visual, speech, language, brainstem, sensory, or retinal. And then followed by that, there should be a motor aura. So if the motor aura is present, then that supersedes all other diagnoses. The diagnosis is hemiplegic migraine, even if there are brainstem symptoms. So again, there are gradual spread of for more than 5 minutes. Usually it's unilateral. It follows the headache usually follows within 60 minutes. But although it usually lasts for 60 minutes, but sometimes it can be longer also. So it can be longer also. And although it's usually unilateral, but sometimes this was an older study from Hayek et al. And there were some patients, very few, 2 patients who had bilateral paresis. So usually it's hemiplegic, but probably in some cases, there can be bilateral involvement also. Now, the major differential diagnosis here is cerebrovascular disease or TIA. And the major differential points are that in TIA or stroke, the onset is sudden as compared to hemiplegic migraine, where there is a gradual progression. And the timing of the headache differs. In TIA or stroke, there will be, if the headache occurs, that will occur later. And in hemiplegic migraine, the headache will occur within 60 minutes. Then other differentials include cerebral amyloid angiopathy, epilepsy with hemiparesis. Again, basically the progression of the aura over 5 to 60 minutes and gradually involvement of the limbs, with focus starting at one point and then involving the other limbs. This is characteristic of a hemiplegic migraine, and it will help in differentiating from other conditions. Importantly, there are certain hereditary or metabolic disorders like MELAS and CADASIL, which lie in the borderland of migraine, because these can have migraine as well as hemiplegia. But again, here the deficits are more of the persistent kind, and there are other clues which will, the MRI and imaging, which will help you in differentiating. So for all patients with hemiplegic migraine, at least some MRI brain is essential. And then obviously we need to take a proper family history, and then a genetic testing can be done to find out whether there is a familial hemiplegic migraine mutation is present. Now, coming on to the migraine with brainstem aura, this has been variably known as earlier as basilar artery migraine, basilar type migraine, Bickerstaff migraine. And basically, usually it occurs in patients with in younger childhood or adolescent onset. Most of the patients, the mean age is almost 20 years. And this was a study conducted by Yang et al. In 2014. In their study, they found that diplopia was the most common aura symptom, though other studies have found that vertigo is probably the most common aura symptom. And then there are various other symptoms like tinnitus, dysarthria, hyperacusia, ataxia, and decreased level of consciousness. The headache which follows migraine with brainstem aura is usually bilateral, and the pain resolves in less than 24 hours in more 2/3 of the patient. It is pulsatile and again moderately severe in intensity, so similar to what the typical migraine attack is. And there can be certain precipitating factors like intense emotional stimuli, weather changes, or sleep pattern disruption. So these are the diagnostic criteria. Important here is to notice, although vertigo alone, we require at least 2 of the following reversible brainstem syndromes. So dysarthria, vertigo, tinnitus, hypocosis, diplopia, and ataxia. You require at least 2 of the reversible aura symptoms. vertigo alone is not enough to make a diagnosis of brainstem aura, and vertigo does not embrace and should be distinguished from dizziness. If there are any motor symptoms, the patient automatically is labeled as hemiplegic migraine rather than migraine with brainstem aura. Now, how does this brainstem aura originate? So there is a debate whether this is occurring because of the brainstem's involvement or it is the cortical involvement. Now, initially it was thought that migraine with brainstem aura is a distinct entity which is distinct from the migraine with typical aura. And there is evidence that there are certain posterior fossa lesions in patients with migraine, both in the brainstem and the cerebellum. So probably the brainstem aura originates from brainstem. But then another school of thought is that this could originate from the cortex itself, and involvement of the various cortical structures could lead to the various symptoms of migraine with brainstem aura. Now again, migraine with brainstem aura is a condition where you should always do an imaging. MRI with contrast is an essential. And optionally, depending upon the clinical situation, we can do a CT, MR, angio, EEG, or lumbar puncture. The differential diagnosis, again, broad. It includes vertebrobasilar TIAs, epilepsy, encephalitis, vascular malformations, glioma, Chiari malformations, and other migraine subtypes like vestibular migraine. But as told earlier, in the vestibular migraine, there will be only vertigo, and other symptoms would not be there. Then there is an entity called confusional migraine, which can also be mistaken for the migraine with brainstem aura. The prognosis is usually favorable as the adolescents and children become adults. The symptoms evolve into a typical migraine, migraine with typical aura, and even sometimes complete remission is possible. The next aura is retinal migraine. So unlike migraine with typical aura, where there is a hemifield aura, here there is a monoocular aura. So in these cases, the patient should be asked that they should look prospectively whether on closing one eye, the aura disappears or not. So if it disappears, then it means that it's monoocular. But if it persists, then it means that there is a hemifield phenomena. So there could be a positive visual phenomena. There could be negative visual phenomena in the form of partial or complete blindness, blurring, grayouts, and then certain complex impairments like tunnel visions, black paint dripping from the corner, coalescence of spots could be seen. Then the relationship is again the headache occurs on the same side as the visual loss, usually within 1 hour, and it's mostly unilateral on the same side, only rarely alternating. Then the duration is usually from minutes to 1 hour, but sometimes it can last for some days to weeks. And it's usually reversible, but certain cases have been reported where there has been an irreversible visual loss also. So these are the diagnostic criteria, and they require that the visual aura, retinal aura, be confirmed either by a clinical visual field examination or the patient's drawing of a monoocular field defect made after a clear instruction. Now, the transient monoocular vision loss can have a vast differential diagnosis, and depending upon the duration, whether it's seconds, minutes, or minutes to hours. So in retinal migraine, it usually lasts for minutes to hours, while in patients with the vascular causes, it usually lasts for minutes. So emerysis fugax, retinal emboli, GCA, and ocular ischemia. And the vision loss lasts for minutes. So this helps in differentiating. And what are the factors that favor retinal migraine over other causes of transient monoocular vision loss? It's that age is usually less than 40. So this is seen in young patients. There is a history of migraine. And then there is a vision loss occurring for minutes to hours. So in any case, in these patients, especially if the age is more than 50, GCA and emerysis fugax with the carotid should be ruled out by doing a vascular study. And obviously, other causes of vision loss, such as drugs, hypercoagulable state, embolic source, all these should also be ruled out by proper imaging techniques. Now, another thing is that typical aura can sometimes occur in patients without a headache. So this is also known as late onset migraine accompaniments. So basically, aura occurs, but the headache does not occur, and it's probably because this is occurring because of a silent cortical spreading depression. Now, it can occur in younger patients and it can occur in older patients. When occurring in older patients, as it's known as late onset migraine accompaniments, and in those cases, it is seen that it is shorter than early onset aura. Frequently, the duration is less than 20 minutes, and the headache, when present, may exhibit non-migrainous features also. And mostly it is a visual aura, but sometimes language disturbances and motor symptoms can also be seen. So when an aura is occurring without headache, then the differential it becomes very important. It needs to be differentiated from either a TIA or seizure. So again, if we know that the aura is a slow progressive symptom which occurs in succession and lasts for around 5 to 60 minutes, in comparison to TIA, which is a sudden, there is no progression, then all the symptoms, they occur almost simultaneously. And the duration usually of a TIA is usually 10 to 15 minutes, so it can also last longer. And in TIA, the positive symptoms are not seen, while in aura, there are positive symptoms. Similarly, there are positive symptoms in seizure also. But the visual symptoms in seizure, they are circular or spherical, in contrast to the linear flashing zigzag lines seen in migraine with aura. And then the visual symptoms in seizure are usually colored, though in migraine with aura, they are black and white, though rarely they may be covered. And fond visual hallucinations may be seen in temporal lobe seizures. They are rare in migraine, may be seen in basilar migraine with brainstem aura. And the sensory symptoms, again, there is a gradual spread in aura, migraine aura. Paresthesias, if present, spread rapidly in a seizure. And the sensory symptoms are less common in TIA, but if they occur, there is no spread. The motor symptoms, they are usually negative in TIA. Again, in aura also they are negative, but in seizures, they will be positive. And the TIAs are usually not stereotypic, while seizures and aura, they have a stereotypic pattern. So these findings can help us in differentiating migraine from migraine aura from TIA or seizures. Coming on to a vestibular migraine, which is a condition which is not is in the appendix of ICHD, and it is a very common cause of episodic vertigo. The other common causes being BPPV and Meniere's disease. So for diagnosing vestibular migraine, we require at least 5 episodes of vestibular symptoms, which include spontaneous vertigo, positional vertigo, visual-induced vertigo, head motion-induced vertigo, or head motion-induced dizziness with nausea. And that should occur either in a patient should have a history of current or previous history of migraine, and in at least 50% of vestibular episodes, a migrainous headache or a visual aura should be present. So if these criteria are not fulfilled, then a diagnosis of probable vestibular migraine can be made if they either have a history of migraine, a current history or past history of migraine, or vestibular symptoms occur in the context of a migraine attack. Either of one, if it's present, we can label it as probable vestibular migraine. So most of the patients who come to the OPD, they will probably meet a criteria of probable vestibular migraine rather than vestibular migraine. So other differential diagnoses like BPPV, Meniere's disease should be ruled out. So positional testing, audiometry, and neuroimaging may be needed in elderly patient. Exclude other causes and try to identify coexisting disorders. So probably in some patients with vestibular migraine, there can be associated BPPV or persistent perceptual postural dizziness. So these can be coexisting disorders. And if a diagnosis of probable vestibular migraine has been made after ruling out other causes, then these can be treated as vestibular migraine. Now, some of these patients will in future meet the criteria for vestibular migraine, but others, they can evolve into typical Meniere's disease. So these patients should be reviewed and monitored and reconsidered if they are non-responsive or the features of the disease change. Now, there are certain primary headaches which can be confused with migraine, though this is very rare because migraine, the headache of migraine and the headache of TTH, one can very easily classify if we ask the proper history and look at the ICHD criteria. So basically in migraine, there will be photophobia and phonophobia. There will be an aura. And most importantly, patients with migraine prefer to lie still. Their headache worsens with physical activity, while in patients with TTH, the headache usually does not worsen with physical activity and does not seriously interfere with the daily activities. The headache is dull aching type in TTH and is throbbing type in migraine. And the onset is more gradual as compared to a rapid onset in patients with migraine. And the duration is for TTH is 30 minutes to 7 days. And migraine usually lasts for 4 to 72 hours, though there may be certain variations. More importantly, another differential is cluster headache. The major differential for differentiating feature for cluster headache is, as we know, cluster headache is a trigeminal autonomic neuralgia. So besides a unilateral side-locked headache, there are unilateral autonomic symptoms in the form of lacrimation, congestion, facial edema, swelling, periorbital swelling, nasal lacrimation, and nasal congestion. So these autonomic symptoms, if present, they indicate that this is a trigeminal autonomic epiphalgia. The headache usually lasts for less than 180 minutes, 15 to 180 minutes, in contrast to migraine, where the headache lasts for 4 to 72 hours. Again, activity or behavior during the attack is very important because patients with migraine tend to lie still, while patients with cluster headache are restless and agitated and often wander around. So, and this is an important differentiating feature. But sometimes, and more importantly, cluster headache, if episodic, can have a cyclical pattern. So it occurs in cycles during a particular season. But then there have been various studies which have found that there is an overlap between migraine and cluster. And this was an older study where they found that patients with
Ashish, can
migraine
you sum
could
it
have.
up? Because
Yes,
I
sir.
think
Yes,
it
sir.
is
I'm
more than
just.
35 minutes.
Yes,
that-
sir. Yes, sir. So there was a migraine can have a cyclical pattern, and there could be patients could have cluster headache patients could have migrainous features. An important differential is that sometimes patients can with migraine can have recurrent limb pain or body pain, and there are several case reports here which have shown that patients with migraine can have limb pain and body pain, and this occurs probably because of the spread of cutaneous allodynia and interictal sensitivity. And this is important because this falls into the differential of neuropathy, fibromyalgia, chronic fatigue syndromes, and other musculoskeletal problems. There are certain episodic syndrome that can be seen in migraine. These are usually seen in children, and one should be aware of these syndromes. And finally, because of the prodrome, postdrome, and the interictal sensitivity, many times patients with migraine are labeled as functional because of the presence of this disequilibrium, vague or fluctuant sensory symptoms without any positive sensory phenomena, positive sensory signs. And they can be labeled as chronic fatigue syndrome or fibromyalgia rather than migraine. And finally, chronic migraine, the diagnostic criteria require that the headache should last for more than 15 days. And of these, more than 8 days should be of the migrainous phenotype. But what is important here is that many patients with chronic migraine lose the typical migrainous features as they progress to chronic migraine. So they may not have typical photophobia, phonophobia, nausea, vomiting. And the past history should always be taken, whether the headache, when it started as an episodic headache, whether these features were there or not. So to summarize, I would say that migraine is not just a headache. It's a neurobiological disorder which can have multisystemic manifestation that can even persist in the interictal state, particularly in patients who are having chronic migraine. Aura can mimic epilepsy, seizures, cerebral amyloid angiopathy. So one should always take a proper history, investigate, particularly for atypical auras. Always rule out secondary causes in case of red flags. And ICSD-3 classification is very useful, and should always be used. But in some atypical cases, misdiagnosis can occur. So thank you.
Thank you, Ashish, for a very comprehensive talk. But we are 10 minutes late almost. So I will request Dr. Francis to take up two questions which are important, and then we move on to the next lecture.
Okay. Thank you, Dr. Debashish. Am I audible?
Yeah.
Okay. So excellent talk, Dr. Ashish.
Thank you, sir.
You covered, I think, all three groups except the group 4, other primary headaches.
Yes.
And I think auras excellently well. I would like to know whether you get these 80% prodromal symptoms. You mentioned 80%, and some of the Western studies telling us 80%. I have been documenting for a long time, but I never get, more than 20%. It is always between 10 to 20%. Yeah.
Yes, sir. The Western studies say it's 80%, but probably if we do a structured questionnaire, probably because many patients may not themselves come forth with these prodromal symptoms. So,
Francis, you asked from the chat box. There are a few questions from the chat box. You can ask one question from there.
Oh, okay.
Do you have access of the chat box?
I'm not getting it. I just try.
Okay. There is an icon called chat, and in that, if you
at the
click
bottom, sir.
at the bottom,
I know. Yeah.
yeah. So you can pick up one question which you think important. Hello.
Yeah, I'm not getting the
Okay,
chat
so
box.
I'll read out a question so you
Okay.
can ask.
Yeah.
So, one is that I think it is an important because he's talked about vestibular migraine. So how to differentiate acute vestibular syndrome from vestibular migraine, Ashish?
Yeah. So basically, in vestibular migraine, there will be recurrent episodes of vertigo. If the patient has for the first time has an acute vestibular syndrome, obviously you need to do the head impulse test and the hints examination, rule out whether if there are the vascular risk factors, then patients may need neuroimaging also. And if there in vestibular migraine, mostly there will be brief episodes of vertigo lasting for 5 to 72 hours. And in at least 50% of them, there will be migraine symptoms, or the patients will have a past history of migraine. So the recurrent episodes, it's vestibular migraine. Obviously, for vestibular migraine, patients can present to you with acute vertigo for the first time. Then the differential of acute vestibular syndrome is broad. And by doing the head impulse test and proper neurological examination or ataxia, nystagmus, skew deviation, if they are present, then patients may require neuroimaging, especially if the vascular risk factors are present.
Okay, thank you. Now I invite Dr. Sumit to kindly share the screen for his presentation. Dr. Sumit, please. And Dr. Girish will moderate after he finishes.
Is my screen visible?
Yes, sir. It is
Yes,
visible, sir.
Visible, but do a slideshow.
Yeah,
Slideshow icon.
just a moment.
Yes, yeah.
Is it okay now?
Yeah. Yes.
Okay.
Yeah.
Just a minute. Mhm. I'm not able to see my screen. Just yes. So very good evening to all of you, and it's a great honor to be speaking on the first webinar of the Headache Society of India, especially under the able guidance of Dr. Debashish Chaudhary as the president and me as the secretary for the society. So I have been assigned this task to speak on the acute management of migraine. So these are my disclosures. So we know that migraine passes through these phases, which has been beautifully described by Dr. Ashish Duggal, where there is a prodrome, and in 20% of cases, there might be an aura, followed by a throbbing, pulsatile, usually disabling headache, which might last for 4 to 72 hours, followed by a postdrome. Now, it is important to understand that the timing of intervention for an acute attack of migraine is of paramount importance. If you look at the pathophysiology of migraine, then in a nutshell, in a person who is genetically predisposed, on exposure to certain triggers in the environment, there's release of certain chemical mediators of inflammation inside the brain, of which currently the blue-eyed boy is the calcitonin gene-related peptide. So because of these mediators of inflammation, which are released, which might be CGRP and some others, like substance P, prostacyclines, and prostaglandins, there is a sterile neurovascular inflammation which leads to hyperexcitable nerve signaling. Now, this causes a sterile neurovascular inflammation, which causes the vasa nervosum to be stimulated, and it is perceived at the level of thalamus as pain, and then later organized and localized at the level of the cortex as the site and the localization of pain. So CGRP currently is a very, very important neurotransmitter, which is finding its way in the pathophysiology of migraine. And it is very important to understand this basic of pathophysiology, because Currently, the treatment paradigm for acute abortive treatment of migraine revolves around this neurotransmitter. We had been actually using different types of interventions in targeting CGRP. So in the past, triptans and the ergots were used to prevent the release of calcitonin gene-related peptide. Lesmeditan also, which is now no more available, also prevents CGRP by acting on certain other types of receptors. Onibotulinum toxin, which we give for the prophylaxis of migraine, also prevents CGRP release. But now we have specific molecules which either act on the CGRP receptors or they act on the CGRP ligand for prophylaxis of migraine. The most interesting and the most exciting part of the abortive treatment of migraine is the availability of these small molecules, which are CGRP receptor antagonists, the GPANTs, of which rimegepant is now available in India. So this, in nutshell, is the pharmacopoeia which is available to us for the treatment of migraine and aborting an acute attack. And if we look at this entire treatment algorithm of migraine, then apart from acute treatment, the preventive treatment, which would be covered by Dr. Debashish, is equally important apart from non-pharmacological interventions. So it is very important to understand that acute medication should be offered to all persons with migraine. If they have an attack of migraine, it should be aborted. It might be a question of providing prophylaxis to many patients, but abortive treatment should be offered to all because usually migraine is an activity limiting headache. And it might be the only medication which might be needed for these individuals if the headaches are too few or infrequent. And if a patient can maintain a headache diary and identify his or her potential triggers, right at the onset of pain, giving an abortive treatment might be the only treatment which might be required for these individuals. There is always a transient gastroparesis because of the autonomic dysfunction, so a prokinetic might be added, even if there is no nausea for a better absorption of the drugs which we give to these patients. So the drugs which are available to us are the triptans, of which elatriptan is not available in India, frovatriptan, naratriptan are not available in India, but otherwise most of the triptans are available in different formulations. So rizatriptan is available as a tablet and a mouth dissolving tablet. Sumatriptan is available as a tablet and a nasal spray. Zolmitriptan is available as a nasal spray. Ergots are available. I have practically no experience in the ergots as an abortive treatment, so I will not be able to cover them with my own experience. There are non-specific treatments like promethazine, prochlorperazine, metoclopramide, diclofenac, and other non-steroidal anti-inflammatory drugs. And then we have rimegepant, which is now available in India. Lesmeditan was available, but this has been taken off shelf by Eli Lilly globally. So it is not available anywhere. So I don't think it merits a detailed discussion apart from its mention. So if we look at the acute treatment guidelines, then we have a level A recommendation for all the triptans. We have recommendations for ergots, non-steroidal anti-inflammatory drug, acetaminophen, and combinations of different drugs, apart from some nasal spray of certain opioids and the GPANTs. The level B is for antiemetics like metoclopramide, antidopaminergic drugs, ergots, non-steroidal anti-inflammatory drugs, magnesium, and a combination of other opioids, which might be safe, but they have a very, very high potential of causing medication overuse headache. Now, whenever we look at the trials which have evaluated any drug which is used for an acute intervention, then we look for a headache relief at 2 hours, headache freedom at 2 hours, sustained pain relief at 2 hours in 2 out of 3 headaches, pain freedom at 2 hours in 2 out of 3 headaches. Improvement in the most bothersome symptom is another new addition in this entire treatment regimen. And if we look at these criteria, then on these criteria, there was a meta-analysis of 25 trials of triptans in headaches, which included more than 3,000 500 patients. So what are triptans? So triptans are 5-hydroxytryptamine 1 and B receptor agonists. They do not cross the blood-brain barrier, so they would be effective only when there is the peripheral sensitization of the pathophysiology of migraine. And these are potent vasoconstrictors. As I told you, several of these molecules are available in India. The route of administration would be choosing according to the symptoms. And in very severe attacks, we had sumatriptan injection available till recently, but now it is slowly going out of shelves. So in the meta-analysis which I was talking to, these were not head-to-head comparisons, but these were as compared to 100 milligrams of sumatriptan, and it was seen that elmatriptan and rizatriptan were the ones which were the most suitable drugs for aborting an attack of migraine. Now, which triptan to give? So one has to understand that these triptans are more similar than they are different. So the triptan which is most suitable or the best for your patient is the best. And as I told you, it should be administered right at the onset of the headache when the headache has just started. Many patients wait and they believe that the headache is going to go away on its own, but it never happens. So if a migraine pain has started, it is not going to abort on its own. If a triptan has to be administered, then the drug should be administered according to the migraine associated features. Like if a patient has too much of nausea or vomiting, a orally dissolving tablet or a nasal spray might be given. So that is the time when a triptan should be administered. There are certain combinations also available of triptans and non-steroidal anti-inflammatory drugs. Many patients do not respond to either, and therefore a combination of them can be offered to these patients. So what happens with the triptans is that there are several issues with their administration. So despite an adequate relief, some users may not achieve an initial response at 2 hours or may experience a relapse within 24 hours of the initial dose, and this is seen in up to 40% of the users. Variable degree of pain relief and pain freedom within 2 hours is observed in different levels of studies. And across several randomized controlled trials and observational studies, many of these patients would have a recurrence or a rebound headache, and they tend to overuse their triptans over a period of time, and they might develop what we call as a medication overuse headache, in which a patient starts to develop headache because of the triptans. So the common side effects of triptans are the dizziness, a sensation of regional heaviness, tightness, pain or pressure, nausea and or vomiting. They are contraindicated in those individuals who have a hypersensitivity or are concomitantly using ergots. They are contraindicated also in those patients who have coronary artery disease or a past history of a cerebrovascular accident. It should be given with caution in individuals who have coronary artery disease or risk factors related to it. Serotonin syndrome has been observed as a side effect, so those patients who are on SSRIs should be given triptans with caution. But the most troublesome part with the triptans is medication overuse headache. So the patients tend to overuse triptan very frequently and they develop MOH very frequently. So lasmiditan was offered because it crossed the blood-brain barrier and it was effective during an attack of migraine. But the biggest problem was serotonin syndrome, which was common with this drug. There was an abuse potential. And the most common side effect was dizziness. And if a DTAN was prescribed to an individual, he was supposed not to drive or operate heavy machinery for 8 hours. So these side effects forced the industry to withdraw this from the shelves. So let's have an example of an individual. So this is a 42-year-old female who was a single mother. She had headache suggestive of migraine. It was low frequency, 2 attacks in a month, but there were severe ones which were associated with nausea. And it was definitely going to happen during her periods, but intermenstrual migraines were also there. So she was prescribed rizatriptan orally dissolving tablet in the form of 10 milligram tablet. The headache did not go away completely, but she had a very, very severe constriction in the retrosternal area, very severe palpitation and restlessness. So she actually walked into my clinic with an unopened box of zolmitriptan nasal spray. So she was extremely apprehensive about the side effects of the triptans, and she drove to work. And at that time, desmiditan was available, but it was not a good option because driving was not possible if it was to be given to her. So this probably opens up to the era of the G-PANTs, which is the new kid on the block. So the rimegepant is a anti-calcitonin gene-related peptide antibody. It is a small molecule which acts for aborting an attack of migraine, for which it is currently approved in India. So this is the result from a phase 4 randomized double-blinded placebo-controlled efficacy and tolerability trial of rimegepant for acute treatment of migraine in adults who are unsuitable for triptan usage. So these patients were prescribed a single tablet of rimegepant in aborting an attack of migraine. And once they had taken this one tablet of triptan for one attack of migraine, about 9 days after, they entered into the open label phase in which they could take the rimegepant as and when they needed. The rimegepant was found to be superior to placebo for the primary endpoint for 2 hours of pain relief. And in all the parameters which I have alluded to earlier, the drug was far superior to the placebo in this particular trial. If you look at the adverse events, now this is something which is really exciting because the drug caused lesser side effect as compared to the placebo in terms of severe adverse events. There were practically no side effects with the drug. The only thing which was found was a odd Raynaud phenomenon in a couple of patients. So this was the open label phase, and this was a pooled analysis of the previous phase 3 trials for the acute treatment of migraine, where the baseline characteristics of the individuals were similar. And a post hoc analysis of this pooled data, it was observed that the most bothersome symptom of migraine and the pain was significantly better responding to the drug as compared to the matching placebo. So if we look at all these 3 migraine specific medications, obviously we have to remove the DTANs from this list now. The triptans are very effective, but they probably have the maximum side effects in general, and the cardiovascular and the cerebrovascular side effects are very, very significant with the triptans. The G-PANTs are probably a little less effective, but their side effect profile, particularly in terms of causing medication overuse headache, is something which gives them a point above the other drugs. Now, if we look at another which is happening in the horizon of treatment of migraine, and that is neuromodulation, which evolved in the era of treatment of migraine somewhere in 2013, where Cifely was probably introduced for the first time in the world. And then came the present device, which is now available in India as Narivio Migra, which is a remote electrical neuromodulation device, which is like a blood pressure instrument which you tie across your arm, and you stimulate it by an app which you can download on your mobile and control this device with this. So these are the other types of neuromodulation devices which are available across the world, but REN is available in India. So it basically trains your brain to control your pain. That is how I can sum up this complex way by which it tends to stimulate the conditioned brain neuromodulation centers in the pons and the descending part of the pain pathway in the medulla. So this device is supposed to be effective in aborting an attack of migraine, and it can also be used in prophylaxis of migraine. Across the world, there are several thousand individuals who are trying this device and have found reasonable relief. The point is that you have to prescribe it as a device which is used for treatment and not as a trial device. And if we compare it with other treatment modalities for aborting an attack of migraine, then it probably scores almost equal to the G-PANTs in terms of its efficacy. And the most important part is that it does not have any significant side effects. So it can be used for both as a prophylaxis of migraine and the acute treatment of migraine. The target population for this particular device would be children, adolescents, and adults alike. And this is the only approved device for treatment in children and adolescents for the acute abortive treatment of migraine. And another good point is that we don't have a drug which can be used in pregnant ladies whenever they have an attack of migraine for aborting it or for the prophylaxis. And this has been evaluated in patients who are pregnant, and the outcomes of pregnancy, as well as the side effect profile in terms of intrauterine growth retardation or fetal malformations, are much lesser in the device as compared to even the placebo. So this is the app which is visible, and this is how you use it for the stimulation for aborting an attack. So in order to conclude, for several decades, migraine has longed for migraine-specific options. We had been borrowing treatments from other branches of medicines, but now we understand that to the center of the pathophysiology of migraine is probably a molecule which is CGRP, and attending or finding options to address to this molecule might be fruitful for both abortive as well as prophylactic treatment of migraine. So if we look at the abortive part of migraine treatment, then if we look at what is available to us, I think there can be two approaches. One is a step-up approach, or the second is a cohesive approach. A step-up approach would be giving an antiemetic for nausea and vomiting and a non-steroidal anti-inflammatory drug. Acetaminophen if it is contraindicated. If there is an insufficient response to non-steroidals in past attacks, you can graduate to a triptan. But if the patient is triptan unsuitable, which means either he is having side effects, or he is having resistance to triptan, or he is having resistance or refractory to 2 or 3 different types of triptans, then we have the rimagepant, which is available as a treatment option. Of course, the medication, which is rimagepant, is available in India, but it is an expensive option. Therefore, it must be offered with the, I think, a reasonable amount of caution in terms of its cost. But it should also be highlighted that the side effect profile, particularly in terms of medication overuse headache, are minimal with this drug. And in those patients who are not able to either respond, we have neuromodulation devices as a rescue. Thank you very much for your kind attention.
Thank you, sir. It was a very lucid and comprehensive summary of the acute treatment of migraine. And there is one question, sir. What is your algorithm for managing triptan non-responders?
So, see, globally, what is advisable is that triptan non-responders are of 3 types. One is a non-responder, which is not responding to one triptan. Then there would be triptan resistance when 2 triptans are failing. And then there is a triptan refractory patient where 3 triptans fail. In India, before you try 2 triptans, the patient is going to try 2 different doctors, maybe 3 different doctors. So in our city, he can show to 3 headache specialists like Dr. Ashish Duggal, Dr. Debashish, and me on the same day. So what I think is that if a patient is not going to respond to one type of triptan, I would either go in for a GPANT straight away. If a patient is not able to take it or can't afford it, then I can use a GON block, which works very well in many of these patients as an abortive treatment as well as for prophylaxis, or a neuromodulation device, right? Remote electrical neuromodulation.
Thank you, sir. I think, sir, whether we'll go for the next talk, sir?
Can you see the chat box, Girish?
Yes, sir. That is the last question, sir.
So ask the last question. What is the role of steroids?
Okay, that question is not there in my chat box, sir. You can
there's a question.
Ah.
What is the role of steroids in acute management or relapse prevention?
So I think it is a drug which can be evaluated in patients who have status migrainosus and those patients who have a prolonged attack of migraine, then steroids can help in those individuals. But otherwise, as a routine, it is not something which is going to be used for aborting an attack of migraine.
Correct. And obviously, the previous question, what is the algorithm, that has already been discussed by this thing. So I think we will move on to the next presentation.
Yeah, so it's my privilege to invite Dr. Debashish Chaudhary, who is ex-professor and head at GB Pant Hospital and presently the president of Headache Society of India, to tell us about the preventive treatment of migraine.
Can you see my slides?
Yes, sir.
Yes, sir.
Okay, thank you. Thank you so much, Dr. Ashish, Dr. Francis, Dr. Girish, and Dr. Sumit. And as I said, that this is a wonderful opportunity to meet a lot of, my friends, colleagues, students online, although I don't see them. So the foundation has already been laid. The diagnosis of migraine is now possibly much clearer. It can come in many forms and shapes. And once you diagnose it, you know how to manage them in with acute medication. That is very important. But I think the cornerstone of migraine therapy, because it's a chronic neurological disorder, so these patients will have recurrences, and therefore the preventive therapy holds the fort, right? Now, the title is The Often Missed Opportunity. So I'll slightly deal with this actually. So if I say to you that my migraine is under-recognized and under-treated, you probably will not agree. Many of you might not agree because migraine is such a common diagnosis that it has been trivialized for long. And obviously, we try our best to treat the condition. But actually, if you see the data, so this is a trial they call the Cameo study, in which it was done from American patients and one of the most developed nations, right? And if you see that the episodic migraine, the chronic migraine, and all migraine taken together, the reach of acute treatment is just to the tune of about 14%. The preventive treatment is only up to 18%. That means less than 20% of the patients are getting the preventive therapy, even if they are eligible for it. So there is an 80% gap. So when I say it is undertreated, that actually holds true. Now, in this paper, they have very interestingly, suggested 4 barriers. So what are the 4 barriers for this proper care of migraine patients? So these are the 4 barriers that most of the patients, they do not consult a physician. They do not come to the doctor's clinic, right, under consultation, because they think, and you must have encountered patients who tell you, no, sir, I used to have common headaches. Those are common headaches. We should take one aspirin or, Disprin, and it should go off. So, and only when it becomes a recurrent, troublesome, disabling, they come. So under consultation, barrier 1. Accurate diagnosis may be a challenge. That is also very important, right? That is often not made, and people, give all sorts of diagnoses, like just lighting headache, vascular headache, and always getting a CT scan on MRI when in primary headaches, as you know, that will be normal. So then you are lost actually if you have not asked the history properly. Then appropriate treatment is not initiated. And of course, there is a chance that acute medications are overused. So the patient develops a medication overuse, and the patients are either not informed about them, or there is no, the drugs which are, kind of suggested are being misused by the patients. So these are the 4 barriers they considered. And, when you see these 4 barriers, then you see that these barriers are traversed by how many percent of persons, migraine sufferers. For episodic migraine, it's only 8.5%. They actually traverse all these barriers and finally get an optimum treatment. For chronic migraine, it is less than 2%. And for all migraine, it is less than 8%. So there's a huge gap in actually diagnosing and treating migraine optimally. Now, this particular study, because it's an American study and people were surprised that, well, it is happening in America, they actually extended the study to many other European countries. And the results were more or less the same. The same pattern of, very less of number of patients traversing these 4 barriers were found. And a recent French study in which, and among these European studies, actually the French was doing well. But if you see this French study, which was published in 2025, they found out that it is not only low, but the lower prescribing rates were associated with shorter practice duration. That is, people who are coming into the practice, new entrants, right? And they have a negative perceptions of the risk benefit and lack of recent migraine training. But fortunately, in the paper, they also mentioned that the recent migraine training significantly reduced the low prescription rates of prophylactic treatments. So it shows that the basic purpose of having this webinar, that, if you actually can train the physicians well enough, then your prescription rates and optimum therapy output will increase. So this is the basic backdrop with which we'll go. Now the question is when to start preventive. Now people give a lot of recommendations. Various societies are differed slightly. By and large, it is taken about 3 to 4 attacks per month is a wholesome burden, and you should actually start treating them. Some people say 2, some people say 3. But for my personal view, even if it's a single attack, but if it's disabling, it is making the patient lose his activity, the job, the employment on that particular day, and the patient is actually having a lot of disability because of the most bothersome symptoms other than the headache, then that calls for a preventive therapy. And of course, as Dr. Ashish has shown, that there are some special types where we would not like to have another attack, like a hemiplegic migraine, right? That is very, very fearful situation, that suddenly one part of your body becomes paralyzed. And if you diagnose that, then obviously you have to put them on preventives so that they do not have the next attack, irrespective of their attack frequency. The next question is that what to expect from preventive treatment, that what do we want from preventive therapy? First, of course, is we want the reduction in frequency. Now, standard in the medical parlance, in the trials, it has been suggested that for episodic migraine, if you get more than 50% responder rate compared to baseline, then that's a good outcome. But these notions are slowly being broken because of the advancements of new drugs and availability of new drugs, we shall cover later. Second, of course, you want that even if the attacks are happening, they should happen in less severe forms because of your intervention. And finally, the intervention should improve the quality of life. See that despite the availability of new drugs, many patients with a chronic migraine or a resistant migraine may have a substantial reduction, like say, for example, from 24 attacks in a month, it becomes 12. But that does not really improve their quality of life, right? So we want us, now with the availability of newer agents, we want a situation where it is substantially reduced in terms of frequency and severity so that the quality of life also improves. So these are the 3 main expectations by the patients from preventive therapy as well as from the doctors. Now, what are the options? Now, these 7 groups of drugs are now available. So you have a lot, kind of a big basket. And within that basket, you have pockets where, quite a number of drugs are available to be used. You can switch between the drugs, and depending on the patient's responsiveness and indications and contraindications, you can select either one or a combination of drugs to treat migraine effectively, right? So you all know about the standard established oral drugs. The propranolol is the commonest drug to be prescribed as a preventive drug. Amitriptyline, candesartan, not so much popular in India, but in the West and Europe especially, it is popular and it has generally been well tolerated. Flunarizine in India again has been used. Topiramate, divalproex, and venlafaxine. Now, all these drugs actually are repurposed drugs. They came for some other disorders, and then it was found that they are also useful in migraine, and therefore they were started to be used, and then the trials came in. Although all these have a kind of, you can say, a level A, evidence, because at least 2 randomized controlled trials have shown the benefit, but there is a lot of variation in the quality and the rigor of those randomized trials because they were done in an earlier era. But by clinical practice, we know that a substantial proportion of migraine patients do respond to them. But also you have to understand a substantial portion of migraine patients do not respond to them, and they fail 2 or 3 or even 4 established drugs. And therefore, we have to move on to the newer agents. Also, it is important to understand that the role of nutraceuticals is coming up, and we have got certain agents like magnesium, riboflavin, coenzyme Q, and vitamin D, which can be used as an add-on to augment the effect, or to be used in certain populations like children, adolescents, where we are fearful of the adverse effects of the standard established oral drugs. And then, as Dr. Sumit is saying, that now currently the buzzword is the CGRP. We have the CGRP blockers, the small molecules, the GPANs, which can also be used as an acute treatment as well as for preventive treatment. We'll come to that. And the anti-CGRP MAPs, right? The MAPs, monoclonal antibodies directed against the CGRP receptor or the ligand. And we have 4 of them, and at least 3 of them can be used on a subcutaneous route once in a month, whereas 1 eptinezumab is to be used in an infusion form. Botulinum toxin has been available for a long time for chronic migraine and is found to be useful at least to break that cycle, and its effects occurs over time. So I'll not go into the detail because this has all been talked about. I will concentrate more on the newer drugs. As Dr. Sumit is saying, that greater occipital nerve blocks have come up very big way in the recent last 5 years, because it has now been included as a class 1 evidence for an acute management of migraine in an ED, as good as perchlorperazine, right? So this is class 1 evidence, but also for the, prevent greater occipital nerve blocks have come up in the last 5 years. So, and I can, take some pride in saying that I have been, doing a lot of work on this aspect. We'll cover briefly about that also. And finally, the neuromodulation has been told by Dr. Sumit. They are useful for the acute as well as they can be used for the preventive treatment of migraine. Now, this is a complex molecule, the calcitonin gene-related peptide, and it's a 37 amino acid neuropeptide. And it was originally, and it is present ubiquitously in the body in various systems, right? And it is a neuropeptide belonging to the calcitonin family, but has distinct functions rather than, in being involved in the bone metabolism or calcium metabolism. So it has got, the members, other members of this family are calcitonin, amylin, adrenomodulin, and intermedin. It has got 2 forms, alpha and beta, and we are more concerned with the alpha form. And it's a complex structure, as you can see, that it has got a RAMP1 and a CLR region and an RCP region. And finally, it affects by affecting the adenylate cyclase by raising the CMP. Now, the proof of its involvement has come from a lot of studies for the last 30 years. The clinical studies have shown that it is released into the jugular venous system during migraine. The levels in the blood and saliva are increased during acute migraine. Serum levels are elevated indirectly in chronic migraine. And if you infuse patients of migraine with CGRP, that provokes a migraine attack. So therefore, the drugs have come into place. The first were the GPANs. Now, GPAN story is very interesting because the initial studies on the GPANs actually came to naught because of the liver toxicity. So now what we have is a second generation GPANs, and one of them is atogepant. Now, in 2021 paper by Jessica Elani have shown that atogepant, if you give it a 60 milligram per day, actually is a very good drug for the preventive treatment of migraine with very few adverse effects. And in fact, this was a large study comprising about 900 patients. And you can see that compared to the placebo, the benefits in even in a lower dose of 10 milligram, 30 milligram, or 60 milligram are actually substantial. And depending on what dose you give, you can have a gain of about 1.8 to 2 days, and that is very, very substantial for the preventive therapies of migraine. The second study came with the rimegepant. Now, when people started using rimegepant as an acute treatment and people were taking it often, they noted that they not only helped in the acute treatment itself, but the migraine attack frequency also came down substantially. And therefore, the study was done, alternative regimen of oral rimegepant, 75 milligram, and they found again there was a significant benefit compared to the placebo. By 2020s, however, the story began to unfold with this discovery of 4 MABs for migraine treatment. And I think that for the next 20 years, they will become, in addition to the GPANs, mainstay in the treatment of migraine. And once we have this generic versions coming, they will kind of, because nowadays it is costly and only one is available in India. But once this generic versions come, I think just like multiple sclerosis field has exploded, the headache field is also going to, migraine field also going to explode because of the availability. So what they have produced, that they are, you have to see that they are not Ramans. They are not the drugs which you can say that completely takes care of the migraine. If you see the effect compared to placebo, which is about 27 to 38%, the effect here is 43 to 62%. Normally, the standard preventives would give about 50% response, so slightly higher compared to placebo, but still about 35 to 40% patients will not respond to MAPS even. They have difficult migraines, and for them, the new agents like PECAPs are being tested, and we are getting increasing data on that. But I'll not cover that today because we are going to talk about what is available in India. So erinumab is available in India. So what are the for this? Drugs, the convenience of use, once in a month, subcutaneous injection, slightly better efficacy than oral drugs. But more importantly, they are very, very well acceptable and people adhere to it because obviously that cause very little discomfort and adverse effects. And also, unlike the oral drugs, the effect comes pretty early. Within a week or two, you get the starting the effect. And some of my patients actually were super responders. They would just have the effect within a week. And that was unthinkable when you using the standard oral medications. And also, I am yet to see 100% responder rate with the oral agents, but I have seen in about 5 to 6 patients 100% responder rate using the MAPs for ameliorating their migraine attacks. So this is again a very small percentage, but it is definitely there. Some people just respond in a super manner, and that is the great advantage of these drugs. And we have a very large real life data lasting for about 5 years, and we are reasonably comfortable with the side effect profile. And we know, although I agree that some of the side effects come very late, 10 years, 20 years, but so far so good. Of course, against the thing is the cost. It's costly. You cannot give it to every patient. You have to selectively choose. But many of you are working in corporate hospitals, corporate centers where patients can either pay or can have the insurance. And there you should not hold back this drug because this drug is new. Of course, there are certain adverse effects that you need to consider, like constipation for erinumab, local side rash, pruritus, and of course, all the MAPs are not available in the developing. Question is that, are the MAPs good for Indians? Because there might be ethnic variations. We did a study called the Empower study, which included the patients from Asia, Middle East, and Latin America, and where we found almost similar results as the pivotal study done in the West. And based on this particular result, erinumab was approved in India. Does the efficacy persist? If you keep on giving every month, does the efficacy persist? Yes. We have done a Galka study along with the Chinese colleagues, and we have found that even on the open label extension phase, the effect of the drug persists in these patients. So there is no wearing off effect in this group of drugs. And if we compare with the standard medications, now this is an interesting, graphical way of putting it. On one axis, you are having the number of mean change in the mean migraine days. On the other axis, you are having the dropouts due to adverse effects. So you see that this is the CGRP antagonists are the best possibly among all the available drugs that are so far. One direct head-to-head comparison had been made with topiramate, and obviously the eronumab was much better. The dropout rate was much less, 10% versus 38.9%. And also there is a recent study comparing galcanezumab with other oral drugs. And again, it has shown that Galca is doing much better in terms of adherence, side effects, and acceptability. Now, therefore, what has happened that, most of the headache federations guidelines, like the European Headache Federation Guideline 22 update, the American Headache Society position statement, and the International Headache Society have suggested that at least we should consider that it is one of the options. Earlier, you had to have a failure of 2 or 3 preventive drugs to actually give these monoclonal antibodies. But now you can consider them as one of the first line options if the patient doesn't have a specific contraindication, or if the cost and other factors are not, against the usage of this drug. So this is a sea change in our understanding and in our application of the drug that is available for migraine prevention. Of course, there are certain contraindications, and these contraindications are more precautionary rather than evidence-based. So still, because it's an evolving concept, and we know that they do not cause vasoconstriction, so therefore they can be given safely, but still, for the time being, recent stroke, unstable angina, myocardial infarction, history of stroke or myocardial infarction, Raynaud's, pregnancy, lactation, uncontrolled hypertension, severe peripheral artery disease, recent venous thrombosis or embolism, severe constipation, severe skin lesions with poor wound healing, abnormal hair loss, and severe inflammatory disorders, they are relative contraindications of use of these drugs. So you should actually use them judiciously and choose them judiciously. A word or two about the nutraceuticals. Now, another thing which has happened in the recent times is this, that it's not only the pathway or the molecules that have been implicated, but also at the molecular level, what are the organs, the subcellular organelles that are affecting migraine, at least initiation or propagation, that has been come into focus. And one such organelle is mitochondria. And mitochondrial dysfunction has been proposed as an important mediator of initiation and progression of migraine because of resultant oxidative stress, damaged protein, DNA, and neuronal hyperexcitability. And so it has been suggested that a mitochondrial cocktail using a coenzyme Q10, riboflavin, and magnesium, and among them, the evidence for magnesium is the best, especially magnesium salt using threonate as a sulfate, magnesium threonate as a compound. It has been found to be useful, especially as an add-on to these patients. And I know that in India, there has been in recent last 3 years or so, there has been recent increase in the usage of the mitochondrial cocktail therapy for migraine as well. Now, greater occipital nerve injections. Now, these are simple procedures. You have to identify by manual perfusion the greater occipital nerve injection sites. You can do it by ultrasound also, but in day-to-day practice, you can do it by landmark-based palpation method. And then you inject either LA with or with LA local anesthetic, either bupivacaine or lignocaine. We use lignocaine with or without steroids. And the effect is not because of the anesthesia that is produced because of these injections, but because of the neuromodulatory effect and so-called the trigeminocervical complex, where the anterior pathways, the trigeminal system, actually is meeting the posterior pathway, that is the occipital nerve terminals. And this is the actual reason why this modulatory effect is so important, and they actually are affecting. There are a lot of studies which have shown that there are changes in the epigenetics as well as in the generation of a lot of neurotransmitters which change following the greater occipital nerve block. So we did a trial in which we gave it for the chronic migraine patients. We first actually reviewed the literature, and then we did the trial. And we found that, yeah, it significantly decreased the migraine headache days in these patients. And the 50% responder rate was also significantly high in patients who received the greater occipital nerve blocks. Uh, so, uh, so, and this was a substantial study in which we showed that, it is not just, the headache that is improved, but also we showed a lot of patient-reported outcomes that were beneficial for these patients. So based on our study, the three studies were, quoted in a IHS international practice recommendation paper. All these studies were, and then with the recommendation, that recommendation came in that greater occipital nerve blocks with local anesthetics, with or without corticosteroids, have limited evidence of efficacy, but may represent an option for migraine prevention because they need another large double-blind randomized trial to prove this point, and they can also be used in pregnant women. So this is, I think, a great change that has happened because this is the first time the GON blocks have been included in the recommendations of the International Headache Society. And lastly, about the neuromodulation. Now, in the neuromodulation, as Dr. Sumit has shown, the Nerivio device is now available in India. It is a REN device, and you can put a band across your arm and then stimulate. It can be both used for acute purposes, also for preventive purposes. The problem here is this, that you can have only 18 sessions per the instrument, and you need to change the cartridge. And now they were coming up with a longer version, but I think there's some problem has come up, so it is yet not arrived in India. But this actually has offered a lot many patients, especially during pregnancy, especially in children and adolescents, especially in persons who are not willing to use long-term oral drugs and who cannot afford very, very high cost therapies. This is also costly, but this is slightly lesser costlier than the other drugs. So this has actually proved to be useful. And recently we published this, 2026, we published this, the consensus among the Indian neurologists adopting this. And we found that, there is at least 60 to 65% consensus, people thinking that, in their practice, from their practice point of view, that this has been helpful to their patients. Of course, I do agree that some of the patients do not respond, but those who respond, they respond pretty well. And this gives us a choice among all other possibilities, all other possible drugs to treat migraine more effectively. So to conclude, I can only say, ladies and gentlemen, you have the options now. You have a lot of options. You have to use them judiciously. You have to know that which drug, and it is not a thing which will come automatically. It is only come if you are actually paying some attention to your migraine patient and see that what works best for that patient. So there is an art of choosing this, there's an art of providing this, and there is an art of switching this. It looks simple, but it is not simple, I can assure you. And I would suggest that don't miss the opportunity to treat your migraine patients optimally, because now you have a lot of options. Thank you very much for your kind attention.
Thanks, Dr. Debashish, for an excellent disposition on the prophylaxis of migraine. So we have a very, very complicated question, and that is, what defines treatment failure in chronic migraine? Chronic migraine, I think, in itself is a failure of treatment. And the second is, what is your approach to patients with persistent disability despite multiple preventive failures? Early aggressive treatment, reverse chronification, or is chronic migraine biologically entrenched once it's established? I think a difficult one, but I think only you can answer it well.
Yeah, so I think that the first question is that what you
What defines treatment failure?
What defines treatment failure? So for the traditionally in the chronic migraine field, a 30% responder rate is considered adequate. A 30% responder rate from the baseline is considered good, right? If you get a 50% responder rate, that's excellent, right? But now the things are changing because the maps have shown that at least in about 10 to 15% of the patients, you can get a 75% responder rate, right? So in those who respond, they do respond. So I think you need to take into consideration, and also which I have not covered here because of lack of time, is this, that chronic migraine patients have a lot of comorbidities. And these comorbidities include a lot of psychiatric comorbidities. You have to treat them well. That does not mean that the psychiatric comorbidities are the cause of migraine. They are a comorbidity associated with migraine, which is making the migraine refractory. The third thing is this, that whenever I see a chronic migraine, I ask about acute medications, when they are taking, how much they are taking. Most of the patients are taking late. They are getting inadequate doses like ibuprofen 200 milligram, naproxen 250 milligram, paracetamol 500 milligram, aspirin 325 milligram. They are inadequate doses and they are taking late after the central sensitization is happening. And they are taking it frequently after a while. So that is the reason for their chronification. So if you correct that, you will get a very good result even with the standard medications, right? Like topiramate. I always say the two things are different. When you give medications for acute treatment, you give the best possible dose to that patient. But when you give the preventive therapy, start low and go slow and slowly escalate, because you will otherwise lose a chance of a good drug. For example, topiramate, if you start with 50 milligrams BD, then most of the patients will be unable to take it, right? You start low dose and then grow slowly, gradually increase. So I think that is the responder rate you will be looking at. So I'll be happy if I get a 50% responder rate, right? If the patient is not happy and able to afford, then we can, of course, go into the GPANs and the MAPs. Now, as far as your migraine pathophysiology is concerned, no, I don't think that it is entrenched, because there is now enough data to suggest that migraine moves from one spectrum to another, from episodic to chronic, and from chronic back to episodic if you treat them well. So about 1/3 of the patients with chronic migraine actually may revert back to episodic migraine if we treat them well. So it depends on how you treat them and at what stage of their disease they are coming to you. Most of the general practitioners, most of the neurologists who are working at the peripheral level, they usually get migraine which are simpler, which are happening, say, about 3 to 5 attacks per month. They are easy to treat. I recently went to a meeting where a very senior neurologist said in his 30 years of practice, he had only the occasion to use triptan only 5-6 times. That means he's seeing only very simple cases of migraine. But for us, when we see the patients, they are very miserable. They are actually they're at the end of the thread, actually, so to say. Recently, Dr. Sumit sent me a patient, a young girl, a Muslim girl from Rajasthan. She was actually tried everything that was possible, but she was not getting well. So what do we say? That no, we can't do anything for you? No, we have to try. So that is the point. That is not entrenched. But yes, once the chronification process becomes more and more, there is evidence that periaqueductal gray matter has increased deposition of iron, and that probably leads to some degree of structural changes, and it may become an entrenched and chronic or refractory problem in years to come.
Yes, so there would be some patients who would not respond to anything, and then there would be some patients who would respond to practically anything.
Correct.
So I think Dr. Debashish, let's have a concluding remark before we end the session. Any inputs from Dr. Girish or Dr. Francis?
Sir, regarding management of chronic migraine, I think planned management of the drugs which cause less of side effects, and also considering the other things which will cause the chronification, like any change in the weight or any associated anxiety, depression, or intake of any medicines which will predispose the patient to the chronicity. That also may help in our treatment success. And probably all of us should have one structured approach that depending upon the patient and their profile, as Dr. Debashish was telling, each patient gives an opportunity to try and get them out from this chronic migraine. Thank you, sir.
Yes. So, I think if there's nothing else, we hand the proceedings back to the organizers.
Yeah, we would like to thank MedBridge for holding this meeting for us in collaboration with the Headache Society of India, and we hand it over to Dr. Gulshan, please. Is she there? Okay, then we call it a day. Thank you everyone for being with us, and I think we had a reasonable discussion and a reasonable overlay of the entire spectrum of migraine, from diagnosis, acute treatment, and prevention. In subsequent webinars, we'll start and pick up small topics, and we will go and we'll also do some case-based webinars that will allow everyone to actually hone their skills in how to manage difficult to treat migraine patients and other headache disorders.
In the meanwhile, sir, as a secretary of HSI, may I, on your behalf, request all those people who are attending to consider Headache Society of India and become members of the society.
Sure.
We will be shortly coming up with the website and the registration forms.
Okay. Thank you.
Thank you.
Have a good evening.
Thank you. Good night. Yeah.
Thank you so much, everyone.
Thank you all.